now it's our honor to present Dr. BCreelan from Moffitt in Florida to discuss cellular therapies and vaccination in lung cancer.
Well, thanks for the chance to present today on cell therapy and vaccines in lung cancer. These are my disclosures. So I'm going to present in a crowded field 3 key themes: vaccines, CAR and TCR, and TIL. And so why? Well, the dirty truth is in advanced lung cancer, we just don't see the plateaus in progression-free survival that patients would like. Look, our gold standard, carbo-pem-pem, at 5 years, only 7% of patients are alive and progression-free. I call this plateau envy, right? And even in the resected adjuvant setting, with our best tyrosine kinase inhibitor, OC, at 5 years, over half of the patients are already relapsing, are already progressing. Whereas it seems like with cell therapy, we get these plateaus where at 2 years, we are not seeing progression events. Why is that? Whether it's tumor-infiltrating lymphocytes in melanoma, whether it's CD19 CAR T cells in lymphoma, are cell therapy capable of eradicating the very last tumor cell, as we saw with Pasiani's mouse models yesterday. And indeed, cell therapy might be more cost-effective as a one-time treatment. This is a Markov model that the Danish Dutch health systems made, comparing a TIL therapy in melanoma to immune checkpoints, showing that it was actually cost-favorable. But what's the real opinion on this? It's the people right here in the room, right? What are our key opinion leaders saying about cell therapy? Well, right here we have a little bit edited, the biggest and best treatment yet, and very, optimism. Dr. Adeo, promising therapy, promising strategy. Dr. Ford, T cells are able to more effectively target and kill cancer. And, let's just ignore this one. Dr. Masudi saying, CAR Ts, we do see occasional secondary cancers. However, what's the most important opinion for us in the United States? It's our future health secretary, right? And in addition to cell therapy, which apparently he likes, he also endorses raw milk, chelating therapy, ivermectin, and psychedelics. So, roller coaster ahead for us. So how does it work? Well, with TIL, tumor-infiltrating lymphocytes, we resect a tumor, we culture the material in the presence of IL-2, we grow it into an army of billions of T cells, and then we infuse it back in the body after making space for the homeostatic expansion of those cells with lymphodepletion chemo. And we've treated over 300, manufactured over 300 of these actually at our facility now. And we took this into lung cancer a few years ago, and surprisingly, we found a few patients with complete responses, a surprise, I think, to all of us. And this is an example of a patient still in remission today. I'm always shocked when I see her CT scan every 6 months, and her CEA level remains completely undetectable. She had neoantigen reactive TIL to several different mutations in her tumor. And these were primarily CD4 T cells that we went back and discovered in our laboratory. And then here's another patient with EGFR exon 19, not the classic type of patient that conventionally responds to immune therapy, and yet she's had this complete response. This is the case to several MAGE antigens. And so this is just accepted by Nature Cancer, showing that in our trial, we see that the antigen-reactive TILs were associated with clinical benefit as expected, right? So this is a key component of TIL therapy, antigen reactivity. And it makes sense, right, that TIL should be a logical solution to the myriad of resistance mechanisms we see post-TKI. Now, this is an industry-led trial with multiple, these are very beat up, patients seen multiple lines of prior therapy. We do see a signal here, 20% response rate. And a second-line trial, which is ongoing, which many of us in the room are participating in, is seeing maybe more like a 25% response rate on a press release last year. This is an ongoing trial with a registration intent after melanoma to get registration in lung cancer. But a key theme is that the presence of prior PD-1 antibody tends to beat up our T cells. And so giving this type of therapy earlier, before this has been, at least in melanoma, shown to have a higher response rate. Now, along those lines, we just presented at SITC a few months ago what happens when we combine PD-1 antibody with TIL for treatment-naive patients. And in this case, for patients that had never seen PD-1 antibody, we saw a 64% response rate, and primarily these were patients that were PD-L1 negative. So this could be an attractive solution for patients that are PD-L1 negative that want to avoid continuous systemic therapy. But I will admit, I did a Freedom of Information Act request on the melanoma data from the company, and you see that actually their evaluable population is much less than the actual patients that were enrolled in the trial. And so this is an important caveat with all of our cell therapy, that there's a significant attrition rate with this, and that the presence of antigen reactivity is very important. And another key theme, which is reassuring, the number of IL-2 doses given after this TIL treatment does not correlate with either the response rate nor the response duration in melanoma. How can we avoid IL-2 altogether, though? 3 companies now, 2 have results reported, are showing really superior results by avoiding IL-2 and incorporating a transgene for IL-15 or IL-12 inside the TIL. And with this in mind, I think this will be the way of the future. So to summarize then, we're seeing that the IL-2 or IL-12 or IL-15 transgenes are proposed to revolutionize TIL in lung cancer. And we've seen that antigen selection strategies are not winning out over bulk TIL. And we may have a registration pathway for bulk TIL in second-line lung cancer before long. But this is a patient that I treated, and this is an example of a patient who had neoantigen reactivity to KRAS and P53. And we isolated these TCRs, and yet he still progressed 4 or 5 months later. How did this happen? It turned out he had complete loss of the HLA that presented those neoantigens. So this is a key thing. Even in the resected setting, we see that over half of patients have HLA loss of heterozygosity at baseline. And this happens even more post-PD-1. So this is really a killer for TIL in my view. There's no way to get around this. In fact, over 3 of these alleles are completely missing. So in some cases, we even see complete loss of the HLA gene itself. This is from the TRACERx cohort. And so really, these are clutch things that really show that TIL may not be enough for many patients. The exhaustion of TIL, lack of reactivity, or above all, loss of HLA. Which leads us to a more simpler approach. We can harvest white blood cells, introduce a transgene, which is specific for a single-chain antibody that directly targets this protein on the cell surface of the tumor. And so with CAR T cells, chimerigen antigen receptors, these may win out in some ways over the more HLA-LOH tumors, the LOHA tumors. And so we're in an island right now, so I thought we'd look at the lung as an island and look at the different targets we have. We may be in the north of the island looking at GPC3 or a variety of other CAR targets. And so I'll start with GPC3. So it's overexpressed in over 90% of hepatocellular cancer. Why am I talking about it here? Well, it's also seen in 60% of squamous lung cancers. And what we'll see is that a CAR T that was presented at ASCO last year is showing response rates of over 70% in hepatocellular carcinoma. Importantly, this also includes a double negative TGF-beta sync co-receptor inside the CAR. So this allows it to overcome this suppressive tumor microenvironment. This is a key component of most of the CARs that are coming out in the last 2 years. Again, 70% response rate at the highest dose level. Very few grade 3 toxicities, grade 2 only. I think this is very impressive. We're not seeing that off-tumor, on-target toxicity that we conventionally associate with epithelial CAR T cells. Here's an example of a response in a patient going out to 6 months. Again, these are hepatocellular metastases. And then here's another GPC3 CAR in which they inserted an IL-15 transgene. And only with the addition of the transgene were they able to achieve responses, showing again between 2 different TIL companies and now 1 CAR T company the importance of IL-15 in really conditioning those T cells. What about DLL3, which is a beloved target of us from tarlatamab and other DLL3 agents in registration? Well, Amgen, actually, there was a CAR T cell that came out for DLL3 a couple years ago, only advanced to the second dose level before it was abandoned by the company in favor of tarlatamab, an easier drug to give. But this has the beauty of being a one-time treatment. And in fact, with only a few patients dosed, they were able to show that it was safe at these lower dose levels, and there was no significant grade 3-4 adverse events. And here's an example of what didn't even count as a response, but significant improvement in liver metastases with a patient with small cell lung cancer, and another significant improvement in a patient with small cell lung cancer with this DLL3 CAR T cell. So one of the big advantages of this is it is a one-time treatment. Furthermore, there's a company that's currently enrolling into a phase 1 trial right now that includes what I said, a TGF-beta sync receptor CAR. And this, to me, is a very promising approach, which could potentially replace DLL3 antibodies by specific T-cell engagers for a large portion of the population, just like it's largely replaced it for myeloma and lymphoma. And we should see results from this trial coming out at a meeting soon. What about EGFR or ALK? Well, we've seen CAR Ts for EGFR can work. And I'll revisit this in a moment, but here's an example of a patient with an ongoing PR at 13 months, as reported for targeting EGFR on the cell surface. This isn't mutated EGFR, remember, which is presented by PMHC. But ALK is a really tricky one, because for us, in the lung cancer world, ALK is only aberrantly expressed in the cytoplasm. So we can't use a CAR T to target ALK. But there are investigators, including Dr. Chiarli in Boston, who's been pioneering T-cell receptor therapy against ALK, against the PMHC peptide MHC complex, which presents aberrantly expressed ALK antigens. And I look forward to seeing T-cell receptor therapy coming out for our ALK rearranged patients before long. What about our classical targets? These are the CARs of yesteryear, CEA, mesothelin. I'd be lying if I said that these treatments were manageable toxicity, because with CEA targeting, you end up with colitis. With mesothelin targeting, you end up with pleuritis, peritonitis. And yet, now we're coming out with dual targeting CARs that turn off in the presence of a normal signal, CARs that turn on only in presence of two abnormal signals. Here's an example of that. I just said HLA, it's broken in half of lung cancer. What if you had a CAR that only turns on in the presence of the broken HLA? And that's what this company is doing. This trial's been enrolling, I think, at least 5 to 10 patients, and they're also expanding this into other CAR targets, mesothelin, EGFR. So I look forward to seeing results from this, again, in which the CAR only turns on in the presence of aberrant HLA. But what if you have no target, right, which may be a lot of our patients? So these are researchers at UCLA who actually put a CD19 BiTE inside of a CAR. So the CAR gets activated in the presence of CD19 after infecting the tumor with an oncolytic virus. So this is a little bit more fringe, obviously, but the idea of actually stimulating a tumor to express a target, which is then killed by a CAR, could be an interesting approach. And at Moffitt, the researchers in my lab are currently working on an inducible CAR, TIL. So you take a TIL, you transduce it with a CAR, for example, for HER2, CEA, and the TIL will only activate the CAR, and then the CAR only gets activated in the tumor microenvironment, where it can't hurt normal tissue. So stay tuned for this. Another interesting way to get around the BiTE problem, which we all hate, right? Patient has to come in every week, every 2 weeks for an infusion. What if we just infused a recombinant B cell, which differentiates inside the body and starts secreting bispecific antibodies, inside the patient, because it differentiates into a plasma cell and only really secretes it in the presence of the antigen. This has been shown to work in mice with the CD19, blinatumomab. And while this is a long ways out, this could potentially put our infusion centers out of business. T-cell receptor therapy, I will not cover as much. This is very focused on a few targets right now, primarily neoantigens or experimentally expressed antigens such as cancer testis antigens. Here's an example of a P53 TCR, which is actually applicable to almost 1% of all cancers if we consider the HLA and the neoantigen frequency together. In this case, this patient had a partial response lasting about 9 months, with breast cancer. On the other hand, we've had worse experience in lung cancer because when you combine the low frequency of these cancer testis antigens in this trial, they had to screen 1,600 patients in order to find 10 evaluable patients for the treatment. So a huge haircut, not commercially viable. Despite having a few responses on the trial, this went nowhere. So in fact, I've looked at some of these T-cell receptor antigen pairs. Your chances are actually higher of being killed by a cow than actually finding these combination in some cases. Because yes, the number of cattle deaths in the United States is not zero. So here are the key takeaways that we maybe see revisiting of these classical antigens using multi-pronged gating, that GPC3 and DLL3, in my view, are the most hot targets for CARs right now, and that the lymphodepletion and, the armoring with IL-15 or IL-12 or both with TIL I think is going to be the next step forward. And then briefly, I realized that Dr. Aerts had covered vaccines in more detail. I do, again, believe that vaccines, the optimal area is going to be the minimal disease setting, either in the neoadjuvant or postoperative setting, for those patients that have minimal residual disease detectable by plasma, for example. And of course, this is one of the largest ongoing phase 3 trials, which has already shown a significant progression-free survival benefit, disease-free survival benefit in melanoma. And it really is poised to perhaps transform our adjuvant therapy of lung cancer by inserting up to 34 personalized neogenes into an RNA cassette and giving that as an adjuvant therapy with PD-1 antibody post-resection. So again, patients are often motivated for these type of higher risk therapy because it is a one-time treatment. And thank you.
Thank you.